Yeah, Parveen.
Yeah, so good morning, everyone. And without wasting any more time, let me start the presentation. So, we are looking at prognostic markers for response of disease in AMD. So, how do you define response? Just a couple of slides on that. So, it could be a functional or a morphological response that you look at. So, functional response usually assessed at about 4 months after three monthly injections have been given. Poor response is no change, non responder is drop in vision, and suboptimal or a good response is probably a gain of more than 5 ETDRS letters. And in terms of a quantitative response on OCT, a better than 75% decrease in IRF, SRF, and CRT is a good response. Anything less than 25% decrease is an inadequate response. And before you label anything like a recalcitrant CNV, the definition is that after 6 intravitreal injections and less than 30 days of the last injection, if your patient still has persistent or a refractive, then you will name it as a recalcitrant CNV. So we all know these are the most common manifestations of persistent disease, the IRC and the subretinal fluid. So, other than that, what else can we look at? The predictive markers of response once you have started treating. So, various algorithms have been formed to look at and what are the factors that have been considered. Some epidemiological factors like age of onset. So, later the age of onset, the worse is the prognosis, the longer the duration of disease, the worse is the prognosis. Better visual acuity at baseline, patients do better. And if the patient has a poor vision to begin with, response is not so good. OCT based parameters, most easily accessible is the central retinal thickness, but the central retinal thickness variability will determine the prognosis. So if the variability is fluctuating, increasing in thickness, decreasing in thickness, anything thicker than 425 micron, poor biomarker. If it is very thin also, it's a poor biomarker. CNV size. So smaller CNV, good prognosis, larger eyes or larger CNV, you have more chances of drop in vision. Type of CNV. So type 1, or rather we should say type of MNV. So type 1, better visual acuity, but as you treat, the collapse of type 1 causes geographic atrophy, so initial benefit may become lesser. Type 3, we all know they progress very fast and can result in macular atrophy very soon. Just an example that within 6 months, what was just a drusen earlier, this has progressed to a full blown type 3 MNV, and you can see a large PED with under the PED, there is a vascular growth, and this is how it looks on a multimodal imaging on Octa. And this is the other eye of the patient, so you can see the regression is there, but it has resulted in atrophy, so it's a poor biomarker as well as the as far long as the vision is concerned. Subretinal fibrosis, nearly one fourth of the eyes can have fibrotic scars, and this fibrous tissue generally resilient to anti-VEGF treatment, more commonly seen in type 2 and type 3. And this subretinal hyperreflective material, if present, can definitely increase the rate of subretinal fibrosis. You could have vascular or avascular SREM. Vascular SREM means already there is a type 2 component which has come up, and now there is you can see the flow is present, and this is what is suggestive of a type 2 component which is present. And another case of subretinal fibrosis, you could see a large whitening area here, but when you see the OCT, so this is the type 1 CNV, but this whole area is that of a SREM. So this is not usually very often seen, but when it is seen, it is a poor prognostic marker. You can see after multiple injections, it has come down, but it is not improved visually also so much. Only improvement is 660 to 624. And when you do Octa in this patient, you see it has got some well-formed large trunk, so it's a resistant kind of a CNV which is present, and it's a large network also which is present. You could have subretinal fibrosis in various places, and how would you decide which one to treat, which one not to treat? So this is lot of subretinal fibrosis, but hardly any subretinal fluid. This membrane has subretinal fibrosis, scarring, but still some amount of fluid is present. I would probably still give a trial of anti-VEGF and see if the vision improves. And this again, ORT. So these are the signs where when you know that the vision may not improve. So this has to be probably a lesion which may not benefit by treatment. IRCs above these scars are usually may not be an indication of treatment. Again, large cysts overlying the disciform scar, also not really, patient is not going to benefit by treatment, and these cases were considered for suspending treatment and were defined to be futile lesions where you could give a treatment pause and see whether the treatment is really benefiting the patients or not. Multilayering of PED, again a poor prognostic sign, chronicity of disease, and patient may or may not benefit visually if you continue anti-VEGF treatment. Subretinal hemorrhage, blood repeated hemorrhage is seen very often, and if it is present, usually triggers fibrosis. And you can see this is a case of massive subretinal hemorrhage. Our following treatment, hemorrhage is gone, but look at the amount of fibrosis or scar tissue which has got left behind. So this is a poor prognostic marker. RP atrophy, again, especially it can be, as we had discussed earlier, be associated with MNV at the margin or CNV at the margin, and here the number of injections have definitely to be kept to a minimum to avoid any progression of atrophy. So this I think ma'am had covered previously in her talk, so I will skip this. So are there any OCTA based markers? So OCTA, the disease activity, has been defined as presence of very tiny branching vessels, presence of anastomotic arcades, presence of inner loops, presence of a hypointense halo. And with treatment, you see the peripheral capillary tufts may decrease, the size of CNV may decrease, but sometimes if there is already maturation of the blood vessels, the larger trunks may not decrease actually. So larger the NV area on OCTA, longer the NV length, largest vessel caliber, and the MNV flow. Most of our OCT machines can give us this. You can see the MNV flow. So this may persist in the larger trunks or vessels even while in the periphery the capillaries collapse. So this should not just always be taken as a sign of activity. You need to look for the peripheral capillary tufts, whether they are present or not. You can see here, this is what they call the pruning of the vessel. The size of the new vascularization has decreased. Now, though the fluid is still persistent, I would not want to stop therapy here, because you can see very clearly that this is definitely working, because the size of the MNV as on OCTA is decreasing. And this, you can see, these are the large trunks of a scarred membrane on OCT, but the large trunks may persist. So this is not a sign of disease activity. So no need for treatment here. But you see a single little tiny vessel, you can see here, little bit of fluid. If you treat, it's nearly completely gone. So the early detection of these CNVs on Octa can help you decide. This is another case where I have taken use of OCTA guided treatment. You can see this is a scarred CNV, and here you can see still the CNV seen on network is seen on OCT angiogram. Minimal amount of IRCs comes. You may think whether to treat or not to treat, but if you look carefully on an OCT angio, you can see the small tongue which has crept up. So this is a new lesion. I would not hesitate to treat the patient with anti-VEGF injection. On PCV, these are some specific markers for diagnosis, for treatment, and for prognosis as well. Coming to the OCT markers, you can see a sharp peaked PED and decrease in the reflectivity under the polyp. These are signs of active lesions, and a good response usually results in flattening. So the presence of fluid, presence of intraretinal fluid, presence of PED, height of PED, type of PED, reflectivity of PED, presence of hyporeflective ring under the PL, these are signs of OCT biomarkers in a case of PCV. So just going to the patterns, just a couple of slides more. So they are divided into three patterns. So do they help us in prognostication? The type 1 is the trunk shaped, where it behaves more like a typical AMD and may need respond well to anti-VEGF injections. Type 2 is more of a glomeruli or an ill-defined kind of a pattern, and high recurrence rates and response to anti-VEGF is lesser. Type 3 is like a stick or a small ill-defined lesion. So this is how it looks like on OCT-A. I'll just share one last example. You can see this is a case of PCV. So you have a polyp, but look at the membrane. You don't see a trunk here anyway. This is a large mass, a network of new vessels which is present. Patient underwent almost 4 injections, but the response was very poor. And last, deep learning, artificial intelligence definitely coming up, where we were considering parameters like IRF, PED, and SRF, but now they are actually feeding the computers the whole complete OCT scans with marked up heat maps for SRF, for atrophy, for SHREM, for ellipsoid zone, for disciform scars. So the computers are going to become very, very intelligent, and they may outperform human beings. And tomorrow you will just have to ask computer, shall I inject or shall I not inject? Thank you.